Hello, everybody. Welcome to Grand Rounds on this rainy Monday. Happy to have you here. Happy to have Dr. Linda Rogers with us, who, as you probably know, is the clinical director for the adult asthma program at Mount Sinai and the National Jewish Health Respiratory Institute. Her research interests are on difficult to control and severe refractory asthma, and she's the principal investigator for the REGAIN study, which is real world and genomics data-based insight through network analysis study, which is a longitudinal observational study looking to characterize patients across the spectrum of asthma severity via systems biology and digital technologies. It is always a pleasure to see her. We are happy to welcome Dr. Rogers.
Thank you for that kind introduction. And you said regain very well. And so I kind of didn't want to come back to this group and do another more general asthma talk, although the field is really kind of moving exponentially. So I snuck a little bit of updates in here, particularly insofar as we talk about asthma endotypes, which may be a new word for you, and we'll talk a little bit about what that means. And I debated whether to do this because we're so immersed in COVID right now that it really supplants everything. But a group of your residents and I and Dr. Steiger have actually been looking at this in our institution and our experience with COVID and asthma, and hope to have that published shortly, but it really has made me do a sort of deep dive between the interface between these two conditions and to ask the questions of whether asthma really is a risk factor for poor outcomes of COVID. And so hence this talk, what do we know and what do we still need to learn? So I'd like to sort of, whoops, hold on. So I'd like to frame this by presenting two different scenarios that came to my attention with patients of mine, which I think really reflects on this issue. So one of them is a 30-year-old physician who I see as a patient who has severe eosinophilic asthma. And this is actually a very specific syndrome. And his presentation really reflects on this particular syndrome. This is someone with no history of asthma during childhood and no allergies, who had sudden onset severe asthma in his late 20s, associated with recurrent episodes of acute on chronic sinusitis requiring multiple courses of steroids and antibiotics yearly. This is a 30-year-old who presented to me with an FEV1 of 50% predicted on high-dose inhaled steroids and long-acting beta agonists, and was still requiring multiple courses of steroids per year, and hence the name severe eosinophilic asthma. This is very prototypical for these patients. This is thunderclap asthma, and it's very severe typically from the get-go. But this patient, we started on an anti-IL-5 monoclonal antibody back 2 years ago, and he did phenomenally on this with almost normalization of his lung function and excellent asthma control without inhaled steroids, and in fact, ability to lower his inhaled therapy as well. But he was doing great, but he kind of called me because he had been asked by his leadership to deploy to the COVID wards. And he was wondering about the impact of his treatment on his risk. Which I thought was a very good question, which I was wholly unequipped to answer at the time it was posed to me. And then I'm going to present you another patient, and this is a more prototypical patient in many of our primary care practices. This is a 30-year-old with mild allergic asthma, has not had exacerbations for years, has done well on a low-dose inhaled steroid, has normal lung function, no other health condition, and works in retail, but asked me the same question. His business was closed for a short while, and then they asked him to come back in person, and he asked me, he kind of looked on the CDC website and was told that asthma increases his risk and wondered whether he should be going back to work. And so that's a probably more relevant patient to your guys' practice. And so these two cases beg the question, does asthma increase risk of acquiring COVID, of ending up hospitalized or dying of COVID? Should we even think of asthma as one disease in general? Like, do these two patients have the same disease? And I think that that's a very legitimate question. And is it the same disease as far as COVID risk is concerned? And if not, who can we drill down to who the patients are at risk so we can counsel them appropriately? So I'd like to sort of look at some of the epidemiological data, because that's what we have the most of, and really talk about these first two questions. And many of us dove into this topic sort of when we were subsumed in COVID. And so this timeline you all know, so I'm not going to dwell on it. that this was the mountain we all climbed in April. This is what the city looked like at the first week of April. The timeline, I won't sort of revisit this, but I would say that around this time in March, when the pandemic was declared, many sort of public health societies, including places like NIH and CDC and World Health Organization, sort of started compiling lists of patients with health conditions who they thought might be at risk. And very early on, asthma made that list, although that was really not based on any data that we really had at the time. In fact, the data kind of showed the opposite, and I'm going to share some of that with you. But why was the CDC then concerned about asthma being a risk factor for poor outcomes in COVID? And the reason for that is because viral infections in general are bad for asthma. And we all know this from our personal experiences, but this is a study from 2005. And this study really focuses on the September epidemic of asthma exacerbations. And so this is sort of less prominent in adults, but in kids, if you're a pediatrician, September is sort of the worst time of year for asthma. And if you look across ER data and hospital data, September is the time when we have our peak of asthma epidemics. And so these investigators looked back over a decade ago now about viral infections and whether those were a driver. And there are two interesting points to make here. The cases here are patients with having an asthma exacerbations and the viruses that were identified by PCR, and actually controls children with asthma who are in a stable state. And there's two important points here. One is that viruses are associated with exacerbations here, and the most common ones are typically picornaviruses, most typically rhinoviruses, although RSV is a little probably underrepresented here, but a big factor as well. So about 62% will have any viruses, but actually, if you start doing PCR in the noses of kids with asthma, you find viruses actually, and many of those viruses are not associated with a clinical syndrome. And those may actually have important impacts on immunity as well. And the fact that those children stay asymptomatic with those, the presence of virus in their airways may be an important clue to how asthma interfaces with COVID. If you look at non-SARS coronaviruses, they're not on this list, but coronavirus is a cause of common cold. And although this is an older study and the PCR technology has advanced since then, coronaviruses have been implicated in about 10% of asthma exacerbations. And so there was reason to think that this might be a troublemaker in those with asthma. But the data that came out from China initially didn't reflect that. And so starting here at first, two case series looking at COVID-19 itself out of China, one a larger group out of China and one a smaller case series out of Wuhan. They reported sort of chronic respiratory disease out of this large case of 44,000 patients. Wuhan reported COPD in 1.4% of patients, but they didn't report a single case in asthma in either of these case series, whereas you can see here that diabetes was reflected in patients hospitalized overall in China and specifically in Wuhan around that time. If you go back to SARS-1, people have also looked at this issue. And so this is actually not our current pandemic. This is the SARS-1 pandemic that impacted Toronto, Taiwan, and Hong Kong, and you can sort of see the data here. Now, keep in mind that these data are heavily represented with healthcare workers, but you can see here that although some amount of chronic respiratory disease and COPD is represented in these various small cohorts, asthma is not really making much of an appearance here. And diabetes, you can argue, is overrepresented. And I say overrepresented it because here in this third part of this figure, they really give you the sort of population prevalence of asthma in these various countries. And you can compare that asthma seems to be underrepresented just based on the population prevalence of asthma alone. You would expect it to show up randomly in a certain percentage of patients, whereas diabetes you can sort of see is maybe somewhat overrepresented in the patients who have SARS-1, and perhaps in the either similarly represented or overrepresented in the patients who have COVID-19. And that was one of the case series that started us scratching our heads. And around that time, when I first saw that data in early April presenting the Chinese experience, I went to the New York State COVID tracker website and looked at our mortality data. And this is actually not data from April. This is data from July 24th. But I had updated the slide since that time and didn't want to show the older data, but it was really very similar. And if you start to look at in New York State, we've had as of July 22,000 deaths, and we've tracked comorbidities in the patients that have died. And listed here are the top 10 comorbidities. Again, asthma doesn't even make the top 10 list here. Again, sort of making me scratch our head if you consider that there's a prevalence of asthma of anywhere from 4 to 8% or higher in some areas in New York State. I would expect it to show up higher, even just based on regardless of whether it increases or risk or not. I would have expected to have a more prominent place as just a common chronic illness. And so we started scratching our heads in April, and others started scratching their heads as well. And unfortunately, some of them scratched their heads faster than us because we're still trying to publish our data out of Mount Sinai, and I'll talk about that very briefly. But there have been many case series that have been published, most recently by Skivaki et al., and they've kind of grouped patients into sort of this kind of areas where asthma, COVID-19 is occurring in patients with asthma above and beyond the population prevalence of the disease in that population, and other countries where it seems underrepresented compared to the population prevalence. So you could see the red are the high COVID asthma areas, and the green are the low COVID asthma areas, with UK, Australia, and USA. And I would say USA as a whole. I'm going to drill down to sort of some more localized data in a moment, but those are areas where they're identifying COVID as a risk factor compared to population prevalence, meaning it's overrepresented compared to population prevalence. But I'll argue that that may not be the best metric really to use. And so the one that convinced me that comparing to population prevalence of the disease is not a great metric is this study out of Chicago by Anju Peter's group, who's a good colleague. And this was a really nicely done study looking at the prevalence and characterization of asthma in both hospitalized and non-hospitalized patients in their catchment area. And so they basically looked at all patients with confirmed SARS-CoV-2 that presented to 10 Northwestern affiliated hospitals between March and April. They identified 220 patients out of the first 1,500 patients, and that was about a 14% prevalence of asthma among the inpatients, outpatients. And they have a very similar kind of inner city. Their population resembles ours very closely, I think. And so, you know, to have a 14% prevalence when the asthma prevalence in the city of Chicago is probably about 8% should be really striking on the surface of it all, and should suggest to you that perhaps that asthma is a risk factor for hospitalization with COVID. But they really dived down deep into their population in terms of characterizing it and did several regression models to assess the association both with asthma diagnosis, other comorbidities, and medication use, and did a really deep dive. And so this is what they found. And so age, of course, is a risk factor. Once you go above 40, that really is significant. Interestingly, though, we all know COVID as a sort of a male predominant disease, but asthma in adults is actually a female prominent disease. So you can see a big gender discrepancy here. And so you really can't look at a relationship between asthma and COVID without really adjusting for gender. Asthma is also more prevalent in certain minority race ethnicities. This came out in the data too, and we all know that those are risk factors for COVID as well. But you'll look here in this unadjusted model, when looking at patients comparing asthma and non-asthma patients, there was really nothing there. No difference in hospitalization risk and no difference in mortality. But could some other risk factors be playing a role there? When they started to look at the comorbid conditions in these patients with asthma, you could see here in slide B that patients with asthma have certain comorbidities. These are the expected ones. They have higher risks of allergic rhinitis, nasal polyposis, higher risk of having certain primary immunodeficiencies, particularly in pediatric populations. But there's also a higher rate of some of our really health conditions which have been linked to worse outcomes in COVID. And those include obesity, diabetes, and cardiovascular disease. And so if you're looking at a population of adults with asthma, many of them are going to be traveling with comorbidities that put them at risk. And so you can't analyze their asthma in the absence of looking at their other diseases. So in their models, again, when adjusting for these covariates, age, sex, and race ethnicity, and also adjusting for some of these comorbid diseases, asthma really didn't play out as a risk factor for hospitalization at all in this data set. They then looked at medication use as well. And this is a more difficult slide. In this figure, you can see the rates of controller use in their patients presenting with asthma and COVID infection. And keep in mind, this is about 200 patients. So of their outpatients, only about half of them were on some form of controller therapy, either ICS or ICS-LABA, maybe even a little under half. Disappointing, but not surprising to many of us. Their inpatients had slightly higher use of these medications, and their ICU patients had even higher use of these medications. And that would maybe, at least on the surface, raise some concern that the medications may be associated with higher risk, or that the medications are a reflection of severity of disease and maybe just a marker not of increased risk related to medication, but of more severe asthma. But when these authors adjusted for many of the other covariates that we just mentioned, basically medication use, including inhaled steroids, was not associated with worse outcomes, either inpatient use or need for the ICU. And although that's a fairly small study, it's one of the few ones that have been done on asthma medications, and at least as some initial data to reassure our patients who have concerns about safety of their asthma medications. But there are other countries that have looked at this on a broader population level, and I'm always envious of the data that the UK has access to. And this is something called OpenSafely. And if you haven't looked at some of the OpenSafely data related to COVID, I would encourage you to look at it. So OpenSafely is a health analytics platform that actually maintains data on 40% of England. So that's a massive data set, obviously. And they were able to combine the health records of over 17 million individuals in England to 10,900 COVID-related deaths and look at risk factors associated with death. So this is obviously a massive population-based data set. They chose data between February and May. And not surprisingly, some of the risk factors we've also identified here in the United States came out. Death was associated with male gender, age, social deprivation, and various medical conditions. But if you break it down by disease, it actually becomes very interesting. And I love this graph because it really helps me look at various diseases and understand their risk. And these are the risks of each of these conditions when adjusting for the other conditions. Keep that in mind. So you can see here, age is big. And it's a dose response once for every decade above age 40, your risk is going up incrementally. Gender-related risk we know about. And again, much of the risk factors that have played out here in the United States, obesity, minority race ethnicity, social deprivation, diabetes. And you can see here that they do a little bit more of a nuanced evaluation for it. Hematologic malignancies, other major organ systems diseases, I'm not going to dwell on those. But look where asthma falls. And so asthma here, compared to no asthma, if you are a person with asthma who has not used oral corticosteroids recently, really your risk is null. And that goes back to one of the first two patients I presented. And if you've had recent oral corticosteroid use, there's a really kind of, compared to, I think, other chronic conditions, there's an elevated relative risk, but it's fairly modest. And if you do a little deeper dive into that, so they reported this out as an increase, asthma being a condition that increased risks. But I think if you look at this data a little bit more closely, I'm a little bit more circumspect. So they identified over 2 million, close to 2,500,000 patients with asthma, about 14.2%, who had not had recent oral corticosteroid use. Of those, about 1,200 died for a rate of 0.05%. Out of 290,000 patients who had used oral corticosteroids for their asthma in the last several months, there were 335 deaths. And so when the relative risk is 1.55 when you adjust for age and sex, but when you adjust for all of the other comorbidities that the patients have, even in those patients with oral corticosteroid use, the relative risk is 1.13. And if you look at the absolute rates here, and you compare that relative risk, the absolute risk is low, with maybe a very modestly increased risk if you've used oral corticosteroids in the last year. So although they sort of presented this as asthma is a risk factor, I think it's a pretty modest risk factor compared to many of the other diseases and conditions and risk factors that we looked at in that nice forest plot. And what does oral corticosteroid use represent? They felt that that represented severity of disease, but oral corticosteroid use can represent severity, it could represent control, it could represent adherence, it could represent that you're exacerbation prone, which may be a different animal in terms of a type of asthma patient. Not every asthma patient is exacerbation prone. And it just begs a lot of questions in my mind. You know, as we talked about in the beginning, is asthma even one disease that we should look at as a uniform disease when it comes to COVID risk? And is the risk related to asthma, if there is one, something that's genetic? at all. And so many investigators have started to tease these questions apart. And so I'm going to present another patient who called me around mid-April and sort of show you her course and see if that reflects at all on some of these issues. And so this is a 60-year-old woman with lifelong asthma since early childhood, pan-allergic, aspirin sensitive, and steroid dependent for greater than 10 years. When I met her, she was on 10 milligrams of maintenance dose, but was even wildly uncontrolled on that. That was the minimum amount that kept her out of the hospital. And she was ending up on bursts every 6 to 8 weeks and was ending up hospitalized twice yearly. That was prior to treatment Omelismab, which is an anti-IL-5 receptor monoclonal antibody, which basically really significantly helped her disease. Because of chronic steroid use, she had multiple comorbidities, a BMI of 36 and hypertension. And we were able to get her off chronic oral corticosteroids with anti-IL-5 treatment, but she did need maintenance hydrocortisone for secondary adrenal insufficiency. And so I saw her as her last office visit as the pandemic was breaking out. At that point, I kind of thought a little bit about what to do about her biological. Would that increase her risk of COVID? And given how sick she was off of it, I didn't do anything with her biological because she was so sick off of it. I figured that had to be worse than any risk related to COVID, although I had no data to make that judgment. But then about 2 weeks later, I got a call and by her daughter, and both her and her elderly 80-year-old mother were quarantining at home with flu-like symptoms. And I didn't think this boded well for her. And so again, this is the sickest of the sick. So is she at increased risk? So the COVID, another UK data set has looked at this, and there are some interesting findings that are a little bit surprising. And so this is something called the UK Biobank, and that's a big biobank that's used for a lot of genetic studies in the UK. It's a very kind of homogeneous biobank from a race ethnicity standpoint, but they have about 13% of these 490,000 people have asthma, although it's 95% white. They identified 641 cases of severe COVID using some of their super data sources that they have across the country. And they found that sort of similar to the OpenSafely data, asthma conferred a modestly increased risk when adjusting for confounders. They then decided to see if this was genetic, and they used something called a polygenic risk score. And I'm not going to delve into the depths of what a polygenic risk score is, but it's basically a sum and aggregate of all the alleles that are associated with the diagnosis of asthma. And they did that by asthma as a uniform diagnosis and by different asthma subtypes or phenotypes. And they found that genetics really was pretty irrelevant in this scenario. And so the risk of COVID was not really driven by the polygenic risk score at all. But when they were breaking it down by different sort of subtypes of asthma, in this case, they broke it down by allergic and non-allergic, which is data that they capture in the UK Biobank, and whether or not they had fixed airflow limitation or COPD. And what they found was that it wasn't really genetics that were driving it, but it was actually the asthma subtype, and that the risk for the different asthma subtypes was not the same. So if you see here on this forest plot, this is asthma overall showing this sort of modestly increased odds ratio, but that modestly increased odds ratio is accounted almost completely for by non-allergic asthma, whereas allergic asthma, the risk is fairly null. With the presence of fixed airflow limitation or COPD also accounting for some of the risk. And so this suggests that all patients with asthma are not the same in terms of their risk profile. And that gets to this question of asthma endotype. And so they used very sort of rough data, meaning a self-reported history of allergy or non-allergy to group their different groups of asthma, whereas we sort of tend to group them more by what we call inflammatory endotypes. And these are the types or patterns of inflammation in people with asthma. And this one is the more common one that we're familiar with type 2 inflammation. And we're typically used to calling this allergic or eosinophilic asthma. We're typically used to thinking about this as an allergic disease that happens in childhood associated with hay fever and allergic rhinitis and perhaps eczema. But this actually encompasses a broad range of different patients, including the patients I showed you with this adult onset non-allergic form of the disease, which is actually a defect of the innate immune system driven by B cells, which are innate lymphoid cells, although both of them end up through this common pathway having inflammation that predominates with certain cytokines, including IL-4, IL-5, IL-13, and the hallmark of this type of type 2 endotype is eosinophilic inflammation, be that allergic or non-allergic. But there is another endotype of asthma, which is non-type 2, where eosinophilic inflammation does not seem to play a role. And there's some debate about how common these patients are. This may be present in about half of mild patients, but the numbers are, there's still some debate over that. And these patients have more complex inflammation with Th1 cells, with interferon gamma. They may be infection prone. This may be certain irritant-induced forms of asthma, including asthma in our World Trade Center patients. And this is more poorly understood and a high needs group of patients that really is not very well helped by many of our current therapies, including both inhaled and oral steroids, although they often end up on a lot of them. And so are endotypes important here? And does endotype influence, is it not genetics or the alleles or polygenic risk score that is important, but is it gene expression actually? And does this inflammatory milieu alter gene expression? And so people started to look at this. One thing that asthma researchers do, and what I'm doing in my Regain company, is we like to use the nose as a surrogate to sample the lower airways. And so there are lots of research groups out in the community who have these big banks of nasal swabs and RNA from people's noses. And they started to look at this in terms of the genetics of two proteins and how that reflected on risk of COVID-19. And those two genes that they looked at are the ACE2 gene, which you guys are well familiar with, the angiotensin II receptor, but also something called TMPRSS2. And that actually you may not know as much, but that is a serine protease that, actually activates or primes the spike protein, which is part and parcel with the virus fusing through the cell membrane and entering the cell. And ACE2 and TMPRSS2 are expressed on nasal and bronchial epithelium. And some people have postulated that I think in the beginning they thought of asthma being a risk factor for contracting and doing more poorly with disease. And they wanted to see if ACE2 expression or TMPRSS2 expression in these nasal brushings really varied according to your asthma diagnosis versus controls. And in fact, even by asthma endotype and control, and whether that might reflect on risk. And so there are a couple of interesting studies that have come out of this. And one was by one of our colleagues at our own institution in the Department of Pediatrics and Allergy, where they had this big database and they decided to take a look and see what they found. And so they looked at ACE2 expression in the nasal epithelium of healthy children, both with and without asthma. And up to sort of a young adult age. And they found something very interesting, which may reflect on this issue of age-related association of COVID risk. And they found that basically ACE2 expression in the nasal epithelium of children is actually pretty low compared to older age groups and increases with age. And that was irrespective of asthma. So asthma was really not the driving factor, although keep in mind that children with asthma predominantly have the common type 2 endotype with allergic asthma. And so ACE2 is really low in kids, and this may reflect on their risk of contracting or getting sick with COVID. And so that was a very interesting study. But others have looked at this in adults, and they found that actually ACE2 and TMPR2 didn't really differ that much between healthy and asthma. But the inflammatory milieu becomes very important when you're looking at ACE2 expression. And actually, ACE2 expression is lower in type 2 asthma, and TMPRSS2 is higher in asthma. And how these balance out in terms of risk of COVID is not clear. ACE2 may reflect on likelihood of infection, and then maybe TMPRSS2 has to do with what happens once you become infected, although we don't really know for sure. And others have found this too, this same pattern. In this group, Jackson et al., they looked at allergen sensitization as a marker of the type 2 milieu, and they found that allergen sensitization inversely correlated with ACE2 expression in the nasal epithelium, and that basically non-allergic asthma did not have this reduction in ACE2 expression, and that might be one potential mechanism for the clinical data that we observed of higher risk in these non-allergic asthma patients. And so lastly, what does that mean in terms of viral infections? And so this last group looked at ACE2 and TMPRSS2 expression in a group of children in something called the Gala study. And this is genetics of asthma in Latinos. And so again, they had this big bank of peripheral blood and nasal brushings, and they decided to look at ACE2 and TMPRSS2 expression. And they did this across a diverse ethnic group of population, and they found some differences amongst different ethnic groups. Although again, genetics was not the big driving factor. The big driving factor was actually the presence or absence of type 2 inflammation. The influence of genetics was small. And so again, replicating the prior results, ACE2 was downregulated in type 2 inflammatory milieu, and TMPRSS2 was upregulated. But they found something else interesting, and this goes back to the initial slide I presented you about viruses and asthma. So in this study, they were studying kids when they were not acutely ill. And they found that about 18% of the children in Gala were basically asymptomatically harboring viruses. And this is a breakdown of some of the viruses. And you can see that they had, asymptomatic carriage of coronaviruses here, as you can see them in the sort of blue and green, which were not symptomatic, and that these patients who carried these viruses asymptomatically had basically sort of high levels of type 1 interferon activation. And so they that sort of is a little bit of a head scratcher. So what do you make of that? The relationship between response to viruses and type 2 inflammation. So that gets back to this study, as I said to you too. So just a little bit of a clue has come out of actually some studies that are been studying the mechanism of response to one of our asthma treatments, Omelismab. And so many of you are familiar with Omelismab. That's an anti-IgE monoclonal antibody that we use to treat persistent allergic asthma that's not controlled with other therapies. And getting back to that September viral epidemic, actually people looked at using Omelismab in children to try to blunt that fall viral exacerbation. And that was something called the PROSE study, preventative Omelismab or step-up therapy for severe or all exacerbations. And it was actually extremely effective at doing that. Basically, if you give Omelismab to children with allergic asthma, you markedly reduce their likelihood of fall viral exacerbation. But that's a bit of a head scratcher, right? Why would something that targets an allergic pathway affect fall viral exacerbations? And when people went back and studied the mechanisms of this, they discovered that actually there is a sort of counterregulation between those allergic pathways, particularly the Fc epsilon receptor, which binds anti-IgE, and signaling type 1 interferon signaling in these plasmacytoid dendritic cells, which are very important to both allergic responses and responses to viral infections. And so there is really a mechanism here where interplay between these two things may impact COVID risk. And that idea that innate responses to interferon responses may be important to the course of COVID infection have actually been replicated recently or have been commented upon recently in these two studies that were in Science in October, where these authors postulated that deficiencies in type 1 interferon responses might be responsible for life-threatening COVID infection. And they, in fact, identified that 10% of patients with life-threatening infection had either autoantibodies to type 1 interferon resulting in deficient type 1 immunity, or they had an one of three innate immune defects listed here that were inborn errors of type 1 interferon immunity resulting in severe COVID. And so, but that's questionable. Remember, I said the kids with the viral infections had high levels of type 1 interferon, and here we're saying that low interferon is bad. So which is it, high or low, that's good or bad? It may not be that it's high or low. It may be the type of interferon and the timing of the response. And so this is some data from a mouse model of SARS-1 epidemic, where they looked at these mice and they actually knocked out their interferon signaling pathways and saw what happened with response to infection with the first SARS coronavirus. And what they found was that at least in SARS-1, an early robust interferon 1 response was good as long as it ended pretty quickly. They had a relatively mild course of disease, and they formed sort of neutralizing antibodies as would expected, as shown here in green. However, if they had a delayed interferon response or a dysregulated interferon response, or actually a low, then they had really severe disease and lethal pneumonia. And actually, if you knocked out interferon 1 signaling, they had actually a mild clinical disease, which may be counter to some other viruses. And some other asthma experts have postulated that something similar may be going on here with the two different types of asthma, that it's possible that our non-allergic asthma patients may be having more of this, a dysregulated interferon response, whereas our type 2 high patients may have really a sort of an early and perhaps not completely abrogated but blunted response that may account for their less of a COVID severity. And Others have actually postulated that it may not be the difference in interferon response alters the severity, but in fact, maybe let's just say your type 2 inflammatory response downregulates ACE2, so maybe you're less likely to get infected. But once you get infected, there may be deficits of your interferon response that may portend a more serious course, or that the more serious course is really overwhelmingly dictated by these type 2 patients who actually have multiple other comorbidities that may portend their risks. And so these are some theories that really remain to be further evaluated. But what's actually happened to patients with asthma during the pandemic? Are they ending up in the hospital? Are they ending up in the emergency room? And the answer is no. And no in a very, very striking way. And so this is data from Kenyon et al. That looked at One Health System's asthma ED visits. And you can see here, whoops, this blue line is the 2020 daily average that goes boom after March 18th. So patients stopped coming to the ER for their asthma exacerbations. One wouldn't think that you can control that well. And this gray line is actually their 2016 to 2019 daily average. And so that tends to fluctuate, again, over time. But you can sort of see here that it generally tends to a certain level, although it fluctuates around that level. And so we've had a profound decrease in asthma admissions and hospital presentations for acute asthma during the pandemic. And this goes even more broadly to other hospital admissions for other chronic diseases that one would think are not really elective. And so this is data published in Health Affairs in November 2020, and you can sort of see here, this is a large data set from something called Sound Physicians, and this is data from 1 million hospital admissions from 200 hospitals in 36 states. Blue line is total admissions in 2019, orange is total admissions in 2020, and you can see this pandemic dip overall that recovers to about within 90% of its baseline, with about another, depending on where you were, 10 to 20% of that being COVID and a little bit less of it being sort of non-COVID related admissions. And so there's been this drop during the pandemic. It's largely rebounded, although not completely. But what happens when you break that down by disease? And this is really interesting data, and I encourage all hospital administrators to look at this. But you can see here that what happened during the April nadir and then during the summer rebound varied depending on some diseases, with some diseases, emergent diseases, going back to their prior baseline, and other diseases really not going back to their baselines. Like if you take a look at this, acute ST elevation myocardial infarction, one would think, when do you have control about that? But it's interesting to look at respiratory, actually. And so, admissions for pneumonia, COPD, and asthma really remained markedly reduced, even after the nadir back into June and July. And that's again, a bit of a head scratcher. And so what are the things that might be impacting this decrease in asthma exacerbations during the pandemic? And so one possibility is greater adherence to controller medication. And there's at least some data by Kay et al. To look at that. And so Kay et al. Were conducting a study when the pandemic broke out. And that study used devices that you attach to their inhaler, both your maintenance and your reliever inhaler, that give a digital signal to an app, to a database, so you can track people's use of both maintenance and reliever medication. And they actually found a 14.5% relative increase in adherence to controller therapy in this February to March window, which is very interesting. So maybe people are home and they're better at taking their medicines. There was also a marked decrease in PM2.5 during some of the shutdowns related to pandemic. And we all know that air pollution is a big driver of exacerbations. And so that may be a factor as well. What about mask wearing and hand hygiene? Although we're aiming to decrease COVID, are we decreasing some of these other viral induced exacerbation? We don't know. But those are all interesting questions to really look at and study further. And so just to finish up, let's go back to what happened to our patients and sort of how I guided them. So one was this patient, which I was really worried about and expected her to get extremely ill. I thought about her as an immunocompromised patient, not necessarily from her asthma biological, which is not really associated with increased of either bacterial or viral infections, but the fact that she was adrenally insufficient and had multiple comorbidities. But actually, she had a relatively mild case of COVID at home with her severe type 2 asthma and did well, as sort of oddly did her mother. So just goes to show you, for all the risk factors in the world, it's difficult to apply these risks to individual patients. This patient, though, I kept off the COVID front lines. I just felt as if the data was incomplete enough that I thought that, and the staff at his institution was robust enough that I thought that he could do other clinical activities and make his contribution in other ways. Whereas this patient, I really, based on the OpenSafely data and the UK data, I don't think that this patient really is higher risk than the average person and probably should be taking the same precautions as anyone going into that workplace. And so I think there is some data to guide management of this milder patient, which is maybe a milder patient without comorbidities, normal lung function, no oral corticosteroids recently. So just to sort of recap and make some take-home points and sort of leave us some time to answer questions, I would say the take-home points are that these large population-based cohorts have found a modest increased risk of death due to COVID-19 infection in those with asthma. Recent oral corticosteroid use may be a marker at those of risk. I will comment that David Steiger and I, along with some of your junior colleagues in your residency, have looked at this in our population, and we found actually data almost identical to the Chicago group, but we actually found a reduced risk in our patients with peripheral eosinophilia. We're trying to get that published now, and perhaps I could share that with you going forward. But that to date, data don't support that a diagnosis of asthma increases risk of hospitalization or intubation. But risk may differ across the spectrum of what is really a syndrome more than one disease. The presence of high-risk comorbidities are common with adults with asthma and may strongly influence the outcome of COVID-19 infection. And that it doesn't look like COVID-19 necessarily is a big trigger of asthma exacerbation, as healthcare utilization for asthma has actually plummeted during this pandemic, and that plummet may be multifactorial. That outcomes related this may be related to asthma endotypes, which may modify expression of two factors that are key with the infection from and natural history of this disease, ACE2 and TMPRSS2, and that the modulation of these may not be genetic, but may be related to the inflammatory milieu that's ongoing, and that that inflammatory milieu may all be related to aberrations in interferon responses that, at least in the case of type 2 asthma, may portend favorably for patients with that phenotype of asthma. And that right now, limited data and expert opinion suggest that we should not be modifying any of our asthma therapies during the pandemic, and that those should be continued, at least based on what we know now for the course of disease. And so I will stop there and open this up to questions.
Excellent. Thank you, Dr. Rogers.
Mm-hmm.
So we'll let people unmute themselves and ask questions or enter them in the chat.
Oh, let me see.
Linda, can I ask a question?
Sure, absolutely.
Linda, thank you so much for that wonderful talk. It was so informative and educative. I'd like to ask you a question, and I admit it's a little rhetorical, but I'm using it as an opportunity for you to educate us all. When you're looking at big data, what are the challenges as a research scientist like yourself in trusting that the diagnosis of asthma that has been extracted from big data, not manually extracted, is accurate? What are the things that concern you about the accuracy of that diagnosis?
Yeah. I'm actually fairly concerned about the accuracy of that data. I don't know specifically, I can't comment specifically about accuracy in an EMR, because that's a really hard thing to get to, because what's your gold standard? And so gold standard of asthma diagnosis, there really is no gold standard, right? It's not like you can use, like hypertension, you have specific benchmarks of blood pressure that you could use for diagnosis. Diabetes, you have an A1C. In MI, you have very specific diagnostic criteria. Asthma is a clinical diagnosis supported by physiological data and response to therapy. And in kids, it's usually a pretty accurate diagnosis. In adults, this has been studied, particularly in the UK. When you take an adult with a recent diagnosis of asthma, maybe greater than 5 years, during an adult, if someone's been diagnosed within the last 5 years of asthma, it's wrong probably in a quarter to a third of the time. And so we call a lot of things asthma, and we treat a lot of things with inhaled steroids. So I think there is both overdiagnosis and underdiagnosis in EMRs. And so it is problematic. I think that you are definitely including patients who probably don't have asthma when you use a coding diagnosis, and you probably are missing patients without a coding diagnosis. Now, how to get better than that? Sometimes you can use other things. You could use medications. You can use comorbidities to try to do it, but there is a fundamental flaw there. But then how to go back and then to use these big data sets and verify the diagnosis without, most of these patients are not going to have the physiological standard. And so if you limit it to that, it probably constrains it a little bit too much. One hopes that as you get into these larger populations, that the amount of misdiagnosis really is not significant enough. The question is what is the misdiagnosis rate in something like OpenSafely in using UK primary care practice data? And I'm not sure anyone systematically looked at it, but I do think it is a problem. So it may, yeah. And you and I contended with that. Mm-hmm.
Thank you.
Other questions? All right, well, oh, wait, I think there's some in the chat.
There might be one in the chat here.
Oh, hold on 1 second. I'm just not skilled. Let me just enlarge the chat so
I can read them for you if you want.
Okay, may have been on the comorbidity from Justin Gasper, may have been on the comorbidity slide, but I'm wondering if you can comment on risk for severe disease in active smokers with irritant-related asthma or no asthma conversely. They didn't, I can go back to the
oh, sorry, I just stopped your sharing. You got to
oh, I have to reshare it. I would have to reshare it. Let me actually just go back and look and see if I could just read it off the slide without taking the time to reshare it. So in OpenSafely, let's look at there was weird data in smokers in OpenSafely. Let me see if I can reshare this quickly. Share. So the smoking data is weird, and I don't know what to make of it. If you kind of break this down, using never smokers as a referent, former smokers seem to have a higher risk, and current smokers would imply a lower risk. And obviously that's not a message we want to put out there, really. And I don't really know mechanistically how to really think about that, but there is something interesting there. They did not break down the asthma group by current or former smokers. And they also, they didn't break out COPD independently here, which is a shame for me. And they did not certainly break out chronic respiratory disease by smokers and non-smokers, really, to sort of get at that question of COPD. So has anybody out there have looked at other data with smokers? Because I've seen, if I remember correctly, I think there was some mixed data about risk of smoking and COVID. Anybody have any insight on that? No. And then, I'm sorry, I think I need to get back now to the comments. Oh, here's the chat. Wait, can I get back to the chat?
The other question was on the hypothesis for why eosinophilic asthma may be conferring reduced risk.
Yeah, again, we don't know. There is clearly an interplay between, at the very least, based on that child data, type 2 inflammation where eosinophils are predominant, and interferon-based regulation. So that's one potential hypothesis. Eosinophilia has been looked at in other diseases other than COVID. Peripheral eosinophilia, if David, tell me if I'm remembering this correctly, confers a mortality benefit in ARDS as well. And whether that's something just intrinsic about those patients' immune response and how they respond to infections in general, or if it's specific to specific types of infection. Like, for example, do patients with type 2 inflammation do worse with certain types of infections, but do better with other types of infections? It's not really clear, but I do think that there's an immunological basis there that may have something important to tell us in terms of the relationship between infections in general and exacerbations of asthma, and then sort of specifically for COVID. But I don't think we know. David, was there anything else I'm trying to think about in terms of our hypothesis? And you delved into this literature fairly deeply in our paper.
Well, thanks, Linda. What I recall is that autopsy data, both in Europe and China, shows that patients who succumbed to COVID pneumonia and have an autopsy, there's usually an absence of eosinophils or minimal amount of eosinophils. And remembering that, you know, the patients die of severe ARDS, which is an acute inflammatory process, predominantly neutrophils. So there's a complete or absence of eosinophils. And so whether or not eosinophils are protective or the absence of eosinophils is an epiphenomenon, marker of severity of illness for unclear reasons. Or is it because these patients received steroids because we were throwing everything at these patients and unfortunately failed, and therefore they died after steroids and had eosinopenia as a consequence of steroids. So it's not clear.
Were there any other questions in the chat or?
I think that might
Great.
be everything.
Thank
you
Thanks.
so much for joining us.
My pleasure. I finished perfectly on time. And if anybody else has any questions, feel free to reach out by email. But it was nice seeing you all, and I hope to see you guys again soon.
Excellent. Thank you so much.
Take care. Bye.